My name is Pam Smith. I'm the Division Director with the Department for Medicaid Services over the Division of Long-Term Services and Supports. I want to thank you for coming to our 1915I State Plan SPA Informational Session for serving individuals that are living with serious mental illness and substance use disorder. I am joined in the room by several individuals from the Department for Medicaid Services and from our sister agency. So just real quick, I want to point out Deputy Commissioner Leslie Hoffman and Jody Allen from our behavioral health team, Commissioner Katie Marks with our behavioral health team. And then I know Jessica Wayne is here from Dale with guardianship. And then I thought I saw there's Jason Bagley, also from Department of Behavioral Health and Intellectual Disabilities. And if I forgot anybody, sorry, raise your, identify yourself. I always end up doing that. So.
There is one back there.
Okay, and so on our agenda for today, we are going to talk about the 1915C HCBS waivers and our 1915I state plan amendment. We're going to talk about how those are a little bit the same, how they are different. For the 1915I, which is going to be the focus today, we are going to talk about who's going to be eligible for the services, what services they will be eligible to receive, what providers can deliver those services, and what the next steps are. We are recording this session, so you'll notice I should have introduced Kelly, our wonderful communications person is up here working our Zoom. So we will be recording this session. We recorded a session in Richmond. Once we finish, we will post these on our website. And if you saw on the table, if you didn't have an opportunity to get it when you came in, there's a sheet about kind of how to find us. There is a link for where you can send questions as well as the main website. If you go to that, it will have the presentations from these series of webinars, as well as a ton of other information about the SPA that's been shared to date. A frequently asked questions document that we continue to update. That is a living, breathing document that we update after each of these sessions, and we'll continue to update throughout the life of the program, as well as any other recordings or any other PowerPoints will also be located there. So our objectives for today are to provide an overview of the Medicaid home and community-based services that are currently available in Kentucky. We're going to discuss the purpose and unique program design requirements of our 1915I state plan amendment, also referred to as a SPA. We're going to review the proposed 1915I program design, including the eligibility requirements, the service offerings, and the service providers. And we're going to outline the next steps of the development process, as well as additional upcoming opportunities for stakeholder input. So as you can see, I got ahead of myself and was so happy for everybody to be here and already did our welcome and introductions. So we will get into it. So the first thing we're going to talk about is the overview of the Medicaid home and community-based services. So we're going to talk about what we have right now and the difference between those and the proposed SPA. So what are Medicaid home and community-based services? Traditional Medicaid does not cover all services needed to support people who are aged, living with disabilities in the community. HCBS benefits give states a way to offer Medicaid paid long-term care in the community. And in the community means the individual lives where they choose at a home or a non-institutional setting, such as a residential home or their own home. The differences between the two programs. So the 1915C HCBS Medicaid waivers, which are currently offered in Kentucky, as well as then we're going to talk about the state plan amendment. Both of them offer home and community-based services, but this will be our first 1915I state plan amendment offered in Kentucky. We are still in active development, and we are going to talk about that today. So first, we'll talk a little bit about the 1915C waivers. So what is a 1915C waiver? And what do we have to do to implement that program? So it is a program that provides home and community-based services to support individuals living with disabilities in their community. In order to offer and implement that program, we have to determine who is eligible, what services will be offered, what setting they will be offered in. We have to set rates and payments for providers. We must provide a level of care equal to what an individual would receive in an institution. So if they were living in a nursing facility, we have to demonstrate the cost of care in that home and community-based setting is equal to that or less than the cost of institutional care. And we have to assure the quality of the services and supports that that individual is going to receive. Our current 6 waivers in Kentucky, we have 2 that support individuals living with an acquired brain injury. You'll hear them referred to as the ABI waiver or ABI acute waiver and the ABI long-term care waiver. The ABI acute waiver is for adults with an acquired brain injury who can benefit from intense rehab services. The services are designed to help the participant re-enter the community and function independently. The long-term care ABI waiver is for adults also with a brain injury who've reached a plateau in their rehabilitation level, and they may require maintenance services or ongoing services to continue to live safely in the community. Our largest waiver, which you'll hear referred to as the Home and Community-Based Waiver, or HCB, provides assistance to elderly individuals or to adults or children with physical disabilities to help them live in the community as independently as possible. Our smallest waiver, which is our Model 2 waiver, provides assistance to individuals who are technology dependent. So they are dependent on a ventilator for 12 or more hours a day to allow them to also live in the community as independently as possible. We have 2 waivers that serve individuals with intellectual and developmental disabilities. Our Michelle P. waiver provides assistance in the community to have individuals live as independently as possible. The same with our Supports for Community Living waiver. It offers some more intense supports as well as a residential option. So what is different about the I, and how is it similar to the C? So first, how is it similar? Both programs enable the cabinet to establish a new Medicaid eligibility group to receive these HCBS services. Both programs enable the cabinet to define the supports and services that we include in the benefit. And both programs enable the cabinet to target a program and its menu of services to one or more population using needs-based eligibility criteria. The 2 important ways that it is different for the 1915I is that it is required by CMS to be offered statewide to all eligible individuals. When services are offered within the Medicaid state plan, they are available statewide and there are no cap slots. So you may have heard about a waiting list, or you may hear there are 10,500 slots available in this home and community-based waiver. With the 1915I, there is not a set number of slots. The services are available to any individual that meets the eligibility criteria. Only the 1915I SPA is required by CMS to offer home and community-based services to people who do not yet meet an institutional level of care, which means that the individual does not qualify for nursing home care based on the level of care and services that they need. So if you'll remember the 1915Cs, they have to require a level of care that is similar or the same as someone living in an institution. For the 1915I, they do not have to require that intense of a level of services. So why did we develop a 1915I? Last year, the governor signed Senate Joint Resolution 72, or you may hear it referred to as SJR 72, which directed the cabinet to create a Medicaid program to address current needs for individuals living with severe mental illness in Kentucky. Through multiple interviews with behavioral health advocates and stakeholders, the cabinet also identified additional needs for individuals living with substance use disorder. The next slide is going to cover what we've done to prepare for the SPA. This is one of my favorite slides because I know this has been a long time coming, and it's a footprint that we can see where we started and that the progress that we've made. So to develop the SPA, we've completed several tasks and we are actively working to follow the timeline of activities. We completed policy review of existing HCBS Medicaid programs in Kentucky. We conducted peer state research to understand what other states currently offer in their 1915 I-SPA and services that they offer for individuals living with a serious mental illness or substance use disorder. We completed interviews with multiple Kentucky advocates and stakeholders, as well as staff from peer states that offer similar SPA services for the SMI and SUD populations. We've completed 5 strategic design sessions to consolidate and incorporate recommendations and align on key priorities from stakeholders and subject matter experts. We have completed the process of compiling, drafting, and revising the initial draft of the SPA. We are currently conducting these in-person informational sessions across Kentucky to provide an overview of the initial SPA draft before it is posted for public comment on the cabinet website. We'll talk about that in just a little bit. And finally, we will conduct a 30-day public comment period prior to submitting the application to the Centers for Medicare and Medicaid Services for review. So now the exciting part. Let's talk about what the program is actually going to look like. So what are the factors that will make someone eligible? Individuals who seek services through the 1915 I-SPA will need to meet the following eligibility criteria based on the proposed program design. Age and diagnosis. This includes individuals aged 18 and over with a primary diagnosis of serious mental illness or substance use disorder. We will use 2 assessment tools to determine the level of service needed for an eligible participant, and the appropriate tool will depend on which primary diagnosis the individual has. So we'll use the level of care utilization system, or the LOCUS, for individuals with the primary diagnosis of SMI. We will use the American Society for Addiction Medicine, or the ASAM criteria, for individuals with a primary diagnosis of SUD. The individual will also need to have clear evidence of functional impairment in 2 or more of the following domains. So societal and role functioning. How well is the person able to follow societal limits prescribed by laws, rules, and strong social norms? Their interpersonal functioning. How well a person establishes and maintains personal relationships. Daily living and personal care functioning. How well a person is able to carry out the activities of daily living related to their individual needs, such as personal hygiene, food, clothing, shelter, and transportation. Their physical functioning. We need to consider the person's general health, their nutrition, their strength, their abilities and disabilities, and their illnesses and any injuries. We need to look at the cognitive and intellectual functioning, considering their overall thought processes and memory in relation to what is common for other individuals of the same age, gender, and culture. We will need to look at duration or episodic criteria that includes clinically significant symptoms of behavioral health that have persisted in the individual for a continuous period of at least 2 years, and at least 1 hospitalization for behavioral health in the last 2 years. What factors make someone appropriate for the services? Participants that are eligible for this program may not be eligible for all of the services. Specific services will only be available to individuals that meet certain assessment tool thresholds and risk factors. The 2 assessment tools, the LOCUS and the ASAM assessment, will be a key component to determine eligibility for specific services. Specific service eligibility will be based on the assessed need. For the LOCUS range, we're looking at a level 3 to level 5. A LOCUS level 5 is the level of care indicates that an individual requires medically monitored residential services. Or LOCUS levels 3 and 4, which the level of care indicates that the individual requires high-intensity, community-based, or medically monitored non-residential services. When we consider the ASAM, look at a range of level 1.0 to level 2.5. Level 2.5 is the level of care provides daily oversight for individuals who need daily monitoring, but not 24/7 care. Level 1.0 and 2.1, the level of care provides daily oversight for individuals who typically require outpatient services. We also will look at housing risk factors, and they will be a key component to determine the eligibility for the housing-related services. To be eligible, an individual must demonstrate one of the following risk factors. And I want to highlight again, it is one of these, not all four of them. So it's homelessness, at risk of homelessness based on the Department of Housing and Urban Development HUD definitions, history of frequent or more than once in a year stays in nursing home, inpatient settings with a length of stay of at least 60 days, or an individual was homeless in the prior 24 months, formerly homeless, now residing in the Department of Housing and Urban Development assisted housing. For our services. So case management is our overarching service that will be offered for both populations. Going down this, it's on the left side, services that are eligible to individuals with a primary diagnosis of SMI and or SUD are assisted technology, tenancy supports, supported education, supported employment, and transportation. On the other side, we have, and in the lighter blue, services eligible to individuals with a primary diagnosis of SMI only, which is in-home independent living, supervised residential care, medication management, and planned respite for caregivers. We're going to provide more detail on each of the proposed services over the next few slides, and we'll explain how service coordination will take place. And again, as outlined on this slide, certain services will be available to individuals with a primary diagnosis of SMI and or SUD, while others will only be available to individuals with a primary diagnosis of SMI. The program will offer 3 housing-related services. Supervised residential care, which is a 24/7 staffed residence. It provides up to 24 hours a day of staff supervision to assist individuals residing in a staffed resident, group home, family care home, specialized personal care home, and personal care homes. It's based on the permanent supported housing principles, or the PSH model, and any home and community-based settings requirements. The service goal is to provide individuals with needed residential supports while also empowering community transitions to independent living as an individual demonstrates the need for less support. Tenancy supports, so pre-tenancy and tenancy sustaining supports will assist the participant in identifying and leasing a housing unit that is expected to promote their health and welfare and independence in a housing arrangement that is not provider-owned or controlled. Again, it is based on the PSH model and any home and community-based settings requirements. The service goal is to secure necessary supports, including entitlements and benefits to preserve and maximize independent living. In-home independent living supports. These services may be provided to individuals in their own private housing unit or a housing unit the individual shares with others. This may be a family home, a duplex, or an apartment building. Again, based on the PSH model and those home and community-based settings requirements. And the goal is to provide individuals with assistance and training related to active activities of daily living and instrumental activities of daily living. Additional supports and services to foster community integration and increase independence include supported education, which will promote engagement, sustain participation, and restore an individual's ability to function in the learning environment in order to achieve their desired educational goals. Supported employment provides services and supports to participants in locating and maintaining meaningful competitive employment in their communities. The 1915I will also include 5 additional services to support individuals living with a serious mental illness and or substance use disorder. Assistive technology. This will provide funding and support to obtain equipment, software, and or products that increase independence and support education, employment, recreation, and activities of daily living. Case management. They are going to be the linchpin that provides supports to the individuals to obtain needed support services. They're going to help in developing that most important person-centered service plan, enabling the individuals to identify goals and strategies to meet their goals. Medication management provides support and monitoring for program participants, as well as education and training to facilitate an individual's adherence to prescribed medication. Non-medical transportation services provides access to covered non-medical transportation to community service, leisure activities, and resources. This will not replace the current transportation, non-emergency transportation services that the individuals are eligible for. It will be a supplement to that. Planned respite for caregivers provides opportunities for primary caregivers to receive short-term relief from the duties and care associated with providing unpaid care and supervision for individuals that need that level of ongoing support. So how will case management connect to this program? So you'll see our individual and then our case managers. And then there's just an example of 3 services on this slide. It doesn't mean every individual will get 3 services or every individual only get 3 services. It just is what ended up looking good and fitting on the slide. So there's no meaning by there being just 3 boxes there. So case managers will work closely with each participant to assess their individual needs and their desired outcomes. They will develop a person-centered service plan to help them achieve their goals. They will identify available services and resources. That may include services through the state plan amendment, as well as other state Medicaid services or natural supports or unpaid services. They will ensure overall satisfaction with services and processes. Case managers also ensure that participants have a freedom of choice when selecting service providers and that services are delivered in accordance with conflict-free case management requirements. This means the assessment and coordination of services will be separate from the delivery of services, with the goal to limit any conscious or unconscious bias a case manager or a service agency may have. It's important to note that some participants may be eligible to receive more than the services that are on the slide. We've designed the 1915 SPA services to allow for a range of providers to deliver services to participants and to promote ease of access throughout our Commonwealth. HCBS provider agencies will be eligible to provide many of the proposed services, and additional provider types will also be eligible to provide specific 1915 SPA services. Additional provider types may include home health agencies to provide planned respite for caregivers, community mental health centers to provide supervised residential care, as well as in-home independent living supports, community rehabilitation program approved providers to provide supported education and supported employment services, and other DMS approved providers to provide supported education services. In order to reach stakeholders across the Commonwealth, we chose 5 locations for the in-person information sessions. This is our 4th session, our 2nd recorded session. Tomorrow we will wrap up the last sessions in Owensboro at the Daviess County Fiscal Court. And that one I was making note of because of the time changes, the only one that is on Central Time. So it's 1 o'clock Central Time. So our next steps for the public comment period. We will conduct a 30-day public comment period prior to submitting the 1915 SPA application to CMS for review. We will consider all public comments regarding the 1915 SPA request. The public notice and public comment period provide individuals that receive services, providers, and all interested parties an opportunity to provide input on the proposed 1915 SPA. We will, when it becomes time for the public comment, we'll put out more directions for individuals on how you can provide public comment, including we will have individuals, if someone would like to call in and needs help capturing a comment, we will have individuals that can speak on the phone with them and can capture comments for them that way as well. So just as a reminder, we've recorded this session and it will be posted on our website. And we're really excited to hear your all's feedback.